marketing team here at IMO. Before we get started, I want to take care of a few items for those on this call. First off, this webinar is being recorded and will be available to you after the webinar. Throughout the session, all attendees will be in listen-only mode, but if you have any questions for our presenters, type them in, and we'll get to as many questions as we can at the end during our Q&A session. So as mentioned before, if you have any questions, put them in. With all of this being said, I'm going to pass it over to Dr. Amanda Heideman.
Hi, good afternoon, and thank you for joining us. I have the pleasure of being not only part of the panel today, but also moderating the panel and helping field your questions. So as Jory mentioned, please do send those in. We'd love to get to as many of those as possible. I am the Chief Medical Information Officer at a company called KeyCare, which is a nationwide telehealth organization that's working together with organizations to care for patients across the country. But I came to this journey in problem-based charting through years of being a consultant, working with different health systems, trying to help them move from just using the electronic health record as an automation of the paper record into really using it as a tool and doing things with it that you couldn't possibly do on paper. Including problem-based charting, sharing information, interoperability, et cetera. So I'm very happy to be here, and I'll hand off to Amber to introduce herself.
Yeah, good afternoon, everyone, depending on where you are in the country. My name is Amber Sija, and I'm an internal medicine doc by training. I've been doing informatics for the last 10 years at University of Colorado School of Medicine. And most of my work in the last 5 or so years has been in the EHR training and optimization space, running a program called Sprint. And so through Sprints, I do a lot of work with specialty primary care and surgical clinics on using the EHR in the most efficient way possible. And that includes using problem-based charting. One thing I'll bring to the discussion today is at UC Health, we do have a custom interface for problem-based charting. Where we are now putting in about 100,000 problem-based charting notes per month. So we do have a lot of experience in that area as well, which I'll bring to the conversation. And thanks for having me.
Great. I'd also like to hand off to Jim.
Hi, folks. Jim Thompson. I'm a physician informaticist at IMO. We're hosting this webinar, and from all of us here at IMO, welcome. Thank you for joining us. By way of background, I spent some time in academic internal medicine and a couple of decades or more in the emergency department. And then in recent years, have segued over to the informatics side of things. So we're delighted to have you.
Great, thank you. So whenever you get a group of informaticists together, it's always interesting to hear people's journey, how they came into this field, when they first started using electronic health records. And I know many of us had started implementing electronic health records in the early 2000s. So I know I was fortunate to start my clinical informatics journey. I got asked by a large health system to come out and be their pilot for the paperless office. And that seemed really exciting. I had no idea what that was going to bring as far as my career and moving from, a solo family practice into the world of clinical informatics. But it seems like the implementation of electronic health records really accelerated right around 2009 with the implementation of the Meaningful Use program. And there was a lot of potential for us clinically to be able to really do some novel things with how we kept the patient record and how we cared for patients. But it seems like those systems really tended to focus more on billing and also meeting those meaningful use requirements and meeting the different regulatory requirements rather than really serving clinicians. I know, Amber, I've seen you present on the topic of the problem list before. I think one of the things that we all need to kind of come together on is the definition of the problem list. So for those that may not be as familiar with the problem list, how would you define that to get everybody on the same page?
Yeah, so in terms of the way we define problem list at UC Health, and I've definitely heard similar definitions across the country when I've had these conversations, is anything that's actively being managed for that patient. So that could be that it's a disease that's actively being managed by a specialist and or a primary care doctor. That could be that it is knee pain that's being managed by a physical therapist. That could mean that it's anticoagulation being managed by a pharmacist. So it's basically any active concern or problem that the patient has that someone is actively managing. And there are very few exceptions to that. I know, it's very easy to get into these kind of debates about what belongs on the problem list. I definitely think at UC Health, the biggest exception to what I just said is when the patient has a family history of a personal history of a significant illness that needs surveillance. But again, I would say that requires active management because it's active surveillance. So a personal history of breast cancer 5 years ago or renal cell cancer, something like that.
Yeah, I think that's a really great way to think about it. In working with clinicians and help doing EHR adoption and optimization over the last few years, one of the things that I've run into is organizations are struggling with the idea of managing that problem list. So even if you can get everybody on the same page, that this is important, the actual dealing with the list tends to have some different factors. So, Jim, I know we've talked in the past about just specific barriers to use of the problem list, things like usability, clutter. What are your thoughts about that?
Well, for the problem list in general, I think I'm kind of with Amber. It's tough to put an exact definition of what should be on there and what shouldn't be. What I think we've noticed from the IMO side, and we talk to customers across the country, hundreds, pretty much every major EHR out there, is that in practice, what's happened to the problem list is since the computer doesn't forget anything, it becomes an attic of everything that was said about the patient. And so the idea of problem list management from our perspective, at least, is, how do we take everything in there and put it in front of the clinician in a way that the clinician can actually process it? Because for me, the problem list at some level is what's the clinical picture of my patient that I care about. And so from our perspective, what we've seen is that organizations do have a lot of difficulty, not just sort of defining the problem list, that might be different from doc to doc, but trying to manage it in such a way that it presents a clinical picture. For me, I would say in a nutshell, the biggest part of that is the computer's ability to have a dynamic display. A problem list doesn't just have to be every single thing that ever got put on it in the sequence in which it was put on. It can get organized, it can get minimized for this guy over here, just a summary of the fact that he has diabetes, and over here for the endocrinologist, all 5 problems, et cetera. So I think the important thing is how is that actually presented to the clinician in terms of managing what's on there in the first place and managing the display itself.
I think that's really important. When I tend to go out and work with physicians one-on-one at the elbow, working on optimization, there's a lot of gaps in people understanding what they can actually do within a given EHR system. I think now that we're past kind of that regulatory hump of, meaningful use, which transitioned into MIPS, there's a lot of opportunity for organizations to kind of re-educate their clinicians on what the tools that are in front of them can do, how to use things like organizing and sorting and filtering, as well as just coming up with some paradigms for tidying up the problem list. When problems are resolved, when situations change, when something needs a different level of granularity, maybe a disease is progressing or something like that, but making sure that the users have the tools to know how to do those things. Do I modify a problem or do I resolve a problem? And how does that affect the overall charting? So I think those things are important. From an adoption standpoint, when we really talk about problem-based charting, I think we're talking about, really focusing on the components of the patient's overall condition in a systematic fashion, but in a way that lets us kind of see that patient holistically. So, it's not just that the patient is a collection of problems, but having them grouped in a way that's logical and organized and that we can document on regularly. I think that makes it easier to document the patient's story. So Amber, as you're really getting into maybe physicians that have come in from a training program or somewhere where they've not experienced problem-based charting, how do you best explain that to them to get them to understand what the ultimate goal is and to get their buy-in, which is just so important in adoption?
Yeah, this is definitely a struggle. So I don't want to make it sound like we have it completely figured out. I mean, even though we are such big users of problem-oriented health records, problem-based charting at University of Colorado, it definitely is still a struggle. Interestingly, when you say people coming in from training programs, most people coming in from training programs these days have used an EHR and are familiar with a problem list. It's actually probably people that have been in medicine a little bit longer or were in during the transition from the paper face sheet, right? That's what used to be the problem list, is the paper face sheet in the front of the file folder where things were crossed out and new things were added and those sorts of things. That became the problem list. I think what we do to get buy-in is a couple of things. One, we tie it to financial incentives as much as possible. So for example, the hierarchical condition category codes, the HCC codes that are now telling insurance companies how complex our patients are, that's a big deal, especially at academic medical centers where we have very complex patients. So by telling people that an up-to-date problem list and looking at the problem list with each patient allows you to determine when those codes are billable and make sure you're remember to bill them. That's one way to tie people into problem-less governance, is to say this is important for you, for billing, for financial incentives, for letting insurers know about the complexity of patients. The other thing is just unfortunately tugging at the heartstrings of like doing the right thing. Right? I mean, if you're the patient in this situation, you certainly want your problem list to be represented accurately and fairly. And I'll even tell examples of patients having a difficult time obtaining things like long-term care insurance when something's put erroneously on the problem list. I have a story that I tell about a patient who had syncope on the problem list and then had a hard time getting long-term health insurance because syncope was something that happened 20 years ago, has nothing to do with what's going on with her now, but was persisting on the list. So I think, really bringing the reality of that list to what it means to the patient, to the insurer, to the provider is a way to work on governance.
Yeah, I think we've all seen those situations where something makes its way onto a chart that, may or may not be accurate, and trying to get that corrected can really be a challenge. It's interesting that we're having this conversation now in early October of 2022. Just on the heels of a new phase of implementation of the 21st Century Cures Act. So, now we're in a situation where patients have, the most visibility to their patient medical record that they've ever had, in the history of medical records. I'm wondering if either of you have seen any changes in how organizations are approaching this, based on that increased visibility for patients. Or based on patient comments about the records that they've been able to see in different organizations. I'll let Amber go first and then Jim.
Yeah, so at University of Colorado, our patient access to the problem list actually preceded the Cures Act. So we've actually had this live for patients to be able to see their allergies, their medications, and their problems for at least 5 years, if not longer. And so that didn't change much. What changed for us is more open notes and really allowing patients to see their notes and to see more notes than they had before. We're a big believer in transparency, so most of our information is turned on across the board. But speaking about problem list in particular, it hasn't changed too much for us.
Jim, what are you seeing?
Well, that's a topic near and dear to my heart. 20 years ago, when the internet was sort of first getting popular with clinicians and sharing information, we had a big discussion at my home shop about whether or not to put the patient's results on what we would now call, their personal record out there, their My Chart if you're Epic, for example. And there was an incredible amount of antipathy toward it, to the point where we killed the whole initiative. Now I'm a patient at UC Health. I'm Dr. Sija's facility. And if I'm in the ER, I can literally see my CBC on my chart before the ER clinician sees it. So that's definitely the direction in which we need to go, I think, is to say, look, the patient owns that record. And with respect to problem-oriented charting and, for example, the Open Notes initiative, which I think is fantastic, I think it actually has an indirect driver for the clinician generating that note to know the patient's going to see what you said about them and how you structured it and so on. And so making that note coherent, and not just for other caregivers down the line, but for the patient, I think putting the content of what's on that chart in front of the patient actually helps drive that from a sourcing standpoint, from the clinician creating the note.
Yeah, I think those are some really great points. A lot of organizations are still charting with the traditional SOAP note, subjective, objective, assessment, and plan, as a way of kind of grouping things together. You know, the problem-based charting kind of flips that around a little bit, as far as almost writing kind of a mini SOAP for each problem. Have you seen that gaining traction among the clinicians? You know, whether or not the system kind of mandates them to do that within the EHR, do people really understand how helpful that is, or do you think people are still kind of struggling with that a little bit? We'll throw that one to Amber.
Okay.
Yeah, so I was telling Amanda and Jim earlier about how people at my organization are sort of making a little bit of fun of myself and CT Lan, our CMIO, because we wrote a paper several years ago about APSO notes and putting the assessment and plan for the reader at the top of the note so that the person who's receiving the note has a really good idea of what's going on with the patient. What's changed is when CMS changed their billing guidelines in 2021, and hopefully this is a good time to talk about this, Amanda, but when they changed their guidelines in 2021, what they said was no longer do you have to count your severity, location, radiation for HPI. No longer do you have to count your bullets for physical exam or review of systems. You now can integrate what you think about the patient, whether that's part of their history or their exam, into what you're doing for that problem. So you're going back to being a doctor, you're synthesizing the information into an assessment and you're making a treatment plan. So given that we are now doing that, what I teach a lot of our providers in our organization is that everything, the AP stays at the top, but everything in the SO section really can be templated, you know, sort of attestations and things that you don't necessarily need to highlight. And then you can create a little mini note under the assessment and plan under each problem. Some people are choosing to do that. Some people are still I'd say the majority of people have not moved over to that way of charting. The majority of people are still typing an HPI while the patient's talking and then putting just the assessment and plan at the top. But under each problem, they're kind of being more specific about that assessment than they were before. And slowly I'm trying to get them to move over to putting a short HPI there, only because if you start looking at problem-based charting interfaces, the beauty of a problem-based charting interface is if you show the clinician how the patient presented last time. So in other words, when we go in to see a patient on our schedule today, the first thing you want to know is, what did my last note say? If you're looking at a blank note and you start typing an HPI, by the time you get to write their assessment and plan, at some point you've had to jump back and look at their last note. So if you can see their last note somehow in that interface, in the view of what you're seeing that patient for today, you can see how they presented last time, how they're doing now, and how you plan to move forward. And so that concept of wanting to see that whole trajectory, you know, really, I think, argues toward us putting a mini SOAP note under each A&P entry. It's a little bit of semantics, but I'm a big fan of that, of really including that HPI in each, but it has to be succinct. So
I hear you, Amber, and let me follow up on that and flesh it out just a teeny bit based on sort of the feedback that I get from customers. So, you know, it's at the leadership level, most of our customers, and that's almost everybody in the States, seem to want to get to problem-oriented charting. At the practical level, it's the docs are like, well, what's in it for me? And I don't mean that in a pejorative sense, but just like, how is this going to actually help me take care of it? And within the patient, and within that dynamic is this idea that we essentially bill by encounter, right? So you come in as a patient and I'm going to bill for an encounter. Within that encounter, there might be several problems that need to be addressed. And so if I put on the doc's teaching, look, I'd like you to put a little note about each of these problems, does that break it up into too much of a workload for a clinician? Is there an efficient way for a clinician to actually do this problem-oriented medical record in the 15 or 20 minutes that she gets for that patient, or should just create one note and put all the assessments piled up together?
Yeah, so it's the lumper splitter discussion, right? So you're taking it a little bit farther and saying, do we take a bunch of diagnosis and write one paragraph? I would say the answer is both. There are going to be times when you're a diabetologist and you need diabetes with nephropathy, diabetes with retinopathy, diabetes type 2 uncontrolled, and you want to write one note. So I think we need the vendors to customize it in a way that we can lump if we want, and have a note apply to each of those problems. But I also think there are times when we need to keep those assessments and plans, including the presentation of the patient, separate. And so I think we need that, we need vendors to allow us to be able to be nimble in that space.
We've actually had an audience comment come in, just kind of validating some of the experiences and talking about really needing to get to that what's in it for me to help the clinician understand what is the value of this moving forward, and noted specifically being able to help clinicians to understand that it's useful for potentially getting pre-authorizations approved, clarity for e-prescribing, things like that, to have everything in that one place. And I think that's one of the challenges for us as clinical informaticists. Often we're that bridge between the technology team and the clinical teams, and really helping people understand what the utility of a given problem is or a given functionality is. Finding that thing that's going to click with a particular clinician about how is this new thing that we're trying to implement, how's that going to solve a particular pain point for them. And I think that's important. I wanted to kind of follow up a little bit on what Amber mentioned about, and Jim, about the change in the CMS guidelines. So, this is where the clinician's thought process is really much more important than it was before. It's not about counting those bullets. What have folks seen as far as trends with the so-called note bloat? I think we talk about, the mess that we can get in various clinical documentation from people copying things forward or using overly templated approaches. But now that this change in the coding requirements has really allowed us to kind of let our narrative story shine, are you seeing that kind of change how people document? Are you seeing more of those stories, or is it hard for people to make that transition? Amber?
Yeah, so in terms of, there's so much to say in this space, I would say, first of all. So in terms of getting people to buy, I want to make sure to make a connection for the audience about the connection that I see between CMS 2021 guidelines and the explosion of problem-based charting at our organization. And that is to say that when we said documentation can be streamlined and can follow problem-based charting and doesn't need to have all of these things in it, that's how we got people pushed over to looking at their problem list, is by saying, we can make your documentation more streamlined. So if we can make your documentation more streamlined, therefore, why don't you look at problem list and clean it up? That's how we got people pulled over. We are super fortunate to have a physician builder that built us a really nice interface on top of our underlying EHR. We use Epic at our institution. And so we were lucky to have that interface that streamlined documentation overall. And that's what's drawn our clinicians to using the problem list and cleaning it up a little bit better. But I would say to Amanda's point about CMS and narratives, I don't think that I've really seen a difference in narrative versus not. We have a lot of speech recognition users, and I think even before the CMS guidelines changed, I think they were using, people that use speech recognition use it, people that type, and I don't know that they changed a lot about how they type out assessment plan or HPI in general. But I do think that the problem-based charting interface itself got people thinking about what really needs to be in my note. So in addition to using problem-based charting, we actually moved forward with the CMS changes with a standard APSO note. And we asked everybody across the organization to start thinking about really what had to be there. And we've convinced people to take out med lists. We've convinced lots of specialists to take out past medical, family, surgical, social, because it exists in the chart already. And we've convinced people to really minimize the number of test result citations that they're doing. The only exception to that is that people that, specialists that see patients that are going back into the community where they don't have our instance of the EHR, those people we really have said, go ahead and put the test results there, because you're trying to make that continuity of care with that community specialist that doesn't have your EHR access. So that's the one exception I'd say that we see a lot of, and I actually condone myself, because we want people to be doing team-based care. And if it's by way of the note for those patients, then it's by way of the note.
I want to make a follow-up comment on that based on my long history out in the world, and then Amanda, ask you to comment on it as well. It felt to me like back in almost in the mid 90s, but certainly by 97 or so, when the original billing guidelines come out, that the most efficient way to use an electronic record from a billing perspective is to sort of have a template there that covers all the things, and then maybe I can batch select the review of systems, I can automatically import the labs. And so, for 20 years, the computer has made it relatively easy for me as a clinician to package up an impressive looking encounter record, a note, so to speak, that has everything in it that doesn't tell a good story at all, because it's just template driven to get all these bullets in that are going to get me paid. And it does feel to me like there's a shift in that requirement that you point out, Amber, that I think is going to be critical to avoid this issue that the electronic health record can be really good at creating something that might look good out to a billing service in terms of what was addressed and looked at and so on, but really doesn't tell the patient's story. So in terms of getting back to the narrative, it feels to me like the best documentation has the critical objective elements that are sort of structured in it, and leaves off the ones that are already somewhere else in the record, so I don't get a 5-page note. But somewhere in there is kind of like a little narrative. That's just my personal bias, and I'm curious if either of you feel like we should try to get back, now that we have a little more freedom, to telling a little a narrative story about what's going on with that patient versus everything just being check boxes.
Yeah, I'll go ahead and take that one. I do think people are becoming much more aware of the importance of that narrative, especially with the variety of people that see the documentation now. There's so much interoperability, whether it's between different clinicians that are on the same platform, or through state level health information exchanges, or different things. And even when we're still, we all still have those couple of providers that we have to fax things to out into the community, or they're on a completely separate platform and don't participate in interoperability. But I think everybody's looking for the best way to understand what's going on with that patient and to make sense of it. And sometimes that is, up to the clinician kind of organizing that and presenting that in a way that tells that story, if their system is not configured a way to do that. And that's where I always encourage clinicians to really, understand how your organization handles enhancements to the EHR, how they handle changes to the EHR, and really for those frontline clinicians to help push back on their organizations to make sure they're making the most out of the EHR. Because although there is more effort in doing this than we would like to have, systems have really come a long way. When I went live on my first EHR in 2003, what we have today compared to what we had back then, is just truly amazing. So I think sometimes among clinicians, just because this is so much and we're dealing with so much and we've been through a lot of pressures the last 2 years, we tend to just say, oh, it's not going to get better, it's not going to change. And that's why I encourage people to participate in different committees at their organization. If there's an informatics committee or a super user course or something like that, I think then they better understand when is it important to make that extra effort, to make that narrative a little bit more clear, and when can you simply do, check boxes or templates. All right. One of the things that we often hear, especially with interoperability and with patient access, is now everybody can see everything. And we run into some different issues with, shall we call it, problem list etiquette. So maybe we have a patient who's had a diagnosis which has become more specific over time and needs to be linked to a new problem that's more granular. Amber made some good points about using the HCC codes to help maintain the problem list. But we still see a lot of issues with physicians feeling like their clinical intent is really not conveyed in the problem list. I'm going to give this question to Jim. What have you seen as far as people really working on that problem list etiquette, doing things for cleanup, trying to maintain that clinical intent?
At the CMIO level, certainly, we've had a nearly universal request: how do we get our problem lists better? For the most part, it's how do we get rid of extra clutter that's gathered on there over time, because a computer tends not to forget anything. you'll have a pregnancy there from 5 years ago. I don't think I have a strong opinion on splitters versus lumpers in terms of what should be on the problem list, because we hear both sides. Gee, there's a lot of stuff missing, and there's a lot of, I got 5 ways to talk about this patient's congestive heart failure, or God help us, diabetes, or that sort of thing. So in terms of the etiquette, from our perspective as a vendor, we hear from every single customer that they want the problem lists better. And we've created tools to help try to get them cleaner. But ultimately, that etiquette problem to me boils down to 2 things. One is, should I, as a clinician seeing a patient, clean up something that somebody else put on there? We do see a reluctance for, say, me as a primary care doc not to want to touch the ophthalmologist's problems. And then I think the second issue that we see on there is, should I be in charge of it anyway? I mean, should it fall to me as the person looking at this problem list to clean it up? Those are the 2 biggest kind of sort of etiquette things that I think we see out there. And Amber and Amanda, I'll let you address what maybe the solutions to those might be.
Yeah, I've seen some pretty cool things recently as far as automation and things that people are doing to look at problems over time. And a lot of times clinicians are afraid of automation. They're afraid of the system making something harder for them to find. But even for those organizations that have been on a robust electronic health record for a long time, even something as simple as removing, Jim, your example of the pregnancy diagnosis, that, or resolving it. We never want to remove anything, but we want to resolve it or make it inactive depending on what happens in our system. But, we know after, 24 months that pregnancy is not still an active problem. Or I see organizations looking at specific groups of problems or diagnoses based on, the fact that it may be denoted by an acute nature, even in the name of the problem, removing those after a period of time. And I kind of coach organizations to think about, it's not like saying you have to remove this within 90 days, but, let's look at, long gaps at, that people will accept having the system automatically resolve something. If it hasn't been addressed in 5 years or 3 years or whatever the comfort level of that organization is, I think people understand that a little bit more versus, if you just say we're going to automatically resolve problems, I think people assume it's going to happen like immediately or when the antibiotics run out. And that's very sometimes scary to clinicians. They worry about not having all the pieces easily accessible. But I think that also goes back to the training piece and helping make sure that clinicians know how to see inactive problems or resolved problems to be able to pull those into their current thinking. Amber, are you seeing anything different in your travels?
Yeah, I mean, I guess I'd say a few things. I mean, if we clean up things on the back end, like we look at duplicates and we clean those up automatically, I definitely think there's value there, but I don't think that solves the problem of how do we get our clinicians to engage with problem lists, right? We still are missing the value that makes people want to go to the problem list with each encounter, with each patient, and make sure that it's accurate and cleaned up. That value, I feel pretty strongly about that value being in having our documentation also there. So if the documentation is in the problem list, that's what I think is the ultimate solution to cleaning it up. That said, I do think that having conversations like you brought up earlier, Amanda, user groups and things like that, and we have to have these conversations at our organizations to say, why is it important to have up-to-date problem lists? We need to talk about where our value lies in taking care of patients and how the problem list can help with that. I know that's very touchy-feely, but that is, those conversations I think are key. We can automate only so much. We need to really have, stakeholders in the conversation for other things. And I think problem list etiquette is one of those. The other thing that I would say is that patient engagement, I think, is one thing we haven't talked about yet today. So having patients be able to look at their problem list and tell us that these things are no longer relevant. That does happen, right? I mean, now I have patients getting in and saying, why is this still on here? I haven't had this in 5 years. And they can write comments to me in there. And so when I go to reconcile their problems, and if they don't get reconciled, the patients that are really, vocal will say, I've put this in 6 months ago. Why has no one at UC Health taken this off my list? So I think relying on the patients to push us forward as to the value of the problem list is going to be important. Similarly, when we talk about narrative, you know, our patients are doing something called our notes, OUR notes. I think many institutions across the nation are doing it. And what this is a way for the patient to tell their narrative, right? So their narrative is coming into the HPI in the patient's words, and it's not just about us needing to tell their story, it's letting them tell their story. So I do think there's a piece of this conversation, both with problem list etiquette as well as with problem-based charting, that says, how can the patient be part of this team? Because after all, it's their record.
Amber, I want to follow up on one thing you just said that really resonated with me. And that is, like, how do we, if we're talking about sort of the problem list as a center pivot point, how does it become more significant? Or, you know, why do we care about the etiquette around it? If the documentation lives there, in other words, like if the documentation is bound to the problem list, so to speak, if that's a point where I go to for my starting off point, I think that's a really powerful reason to say it's a good reason to get to problem-oriented charting, because now I can see sort of the overall clinical picture in a decent problem list, and I've got incentive, so to speak, to make sure that that problem list is correct, because that is where the documentation is living. It's not on some other tab off somewhere else that I'm going to go mine. And I think that's where the modern electronic health record and its ability to create dynamic displays, I think is so different from the paper paradigm that we started. You know, the modern electronic health record, in theory, if it's built properly, can have a clinical picture of the problem list, the documentation is there, the labs are there, the medications are there, brought together in the focus against that in a dynamic kind of a display that's significantly different from a paper kind of a paradigm where I'm writing a note somewhere and, you know, turn to that tab. So putting the documentation right against the problem in the problem list, I think that just really resonates with me.
Yeah, Jim, I would take it sorry, Amanda. I would just take it one step further to say that what we don't want to do either, though, is just go back to the way of blowing in. So like, say we blow in an ICD-10 code, and then underneath it, it just says continue prior management, or it says continue metformin, or continue whatever. That's where the HPI piece comes in, and those mini SOAP notes under each one. Because if you look back at diabetes and you're pulling up all the notes that have been written on diabetes, and they just say continue metformin, get a foot exam, continue, you know, get an eye exam, whatever, you never really still have a sense of like what's happening with that patient. Like, do they follow an ADA diet? Do they exercise? Like, that's where that like little pieces of HPI mixed, you know, kind of with those under each problem, I think really is going to be the key in the future, because you don't notice that until you've done problem-based charting for a while, but you start to see like it could just become templated if you just put assessment and plan there. So.
Yeah, I think that's a really great point. You know, nobody likes to have to look back, you know, back and back and back to figure out what's going on, or, you know, even just to assign just kind of a, you know, a qualitative comment, you know, doing well, you know, improving, you know, worsening. Even small things like that are important. And we actually just had a great audience comment about the need to force a status assessment. So, you know, whether that's, you know, through the actual problem list functionality itself, requiring an update on an encounter-based basis. There's a really good related question talking about, you know, how we visualize these things and how we maintain the etiquette on that problem list. And the question is, what about the ability to edit the ICD-10 name within reason? You know, there's a lot of ICD-10s out there that, you know, the official ICD description is accurate, but may not necessarily be helpful. So Jim, you're smiling, this question is yours.
Because from our perspective, the answer is a resounding no. Don't let your clinicians attach their idea of a text description to something that is a formally structured external reference code. You know, it's one of those things that sounds great. Hey, ICD-10 said something weird here. I need to put what it really is. All I will say is that over time, for something that needs to be structured terminology, it needs to be probably leftist structured terminology. That's pretty far down the rat holes of the problem list in general. But I don't think clinicians should be able to attach their description to something, you know, that's say an ICD-10 or a SNOMED code. Obviously, what we've tried to do here at IMO is say, look, we get that. Let us give you a description that you want. Amanda, and we'll make that description for you, and then now it will be structured and tied back to the right codes. Amber, feel free to weigh in on that, and I don't mind if you disagree.
Well, I'll tell you, I have a funny story about this. So when I was doing problem-based charting before we had a custom interface, I was one of the type A anal internists that would go in and change the name and say, type 2 diabetes managed by Dr. McDermott or something like that, so that's what it would start saying, is type 2 diabetes managed by Dr. McDermott. The problem is when Dr. McDermott saw the patient, it looked pretty funny for him to blow in a code that said diabetes managed by Michael McDermott because he was the one who was actually managing the patient. So you really have to think about those downstream consequences, not only the inaccuracy of the code over time. So if somebody changes it and it keeps getting propagated and you're billing for a code that the patient doesn't have, just the repercussions to the patient, but also just, what you put there is going to be the same code other people that are also in your instance of Epic and seeing the patient are also using. So it might not be applicable to them. So it's tricky to be able to change it.
Yeah, certainly the ability to have, some kind of synonym or, some kind of additional commentary on the problem list, just to give people that, that flavor, for lack, local color about what's going on with the problem or who's managing it. And I think that goes back to understanding how the EHR is structured. Is there a column that I can display that has the name of the person who's managing it? Is there a column where I can display a synonym that kind of helps me understand more clinically? We've all had those situations where we've had to explain to the patient, an ICD code that makes no sense. And one of my favorites, and when I was in primary care practice, was back in the ICD-9 days, dizziness and giddiness. And that was what went into the system from the ICD dictionary. When you said a patient was dizzy and you hadn't really worked it out what kind of dizziness it was yet. So and I would always have to lead with the patient, you're going to see this on your bill, this is what this means. And you do feel kind of powerless as a clinician, until you get your system configured and you have synonyms and you can see that. So I think that's one of the fun things about meeting different clinical informaticists is we've all had these shared experiences, and just realizing that this really has just evolved so much over the last few decades. This is kind of a tactical question so Amber, thinking about an organization that's not currently doing problem-based charting. So maybe we have a lot of people that are just really entrenched and they think the problem list is just merely a list. What kind of advice would you give to those people as far as moving towards problem-based charting? What are potentially some resources or steps they can take to move in that direction?
Yeah, I mean, I think we all need to be going back to our vendors and talking about how to make a problem-based charting product that works for our clinicians. So I think that's step number one, is that we've got to go straight to the vendors, because if we all create our own custom interfaces, we just will end up with the same, interoperability problems and breaks when we upgrade and things like that. So, but I will say that you need to have a plan to get problem-based charting in the works if you really want to talk, I think, viably about problem list cleanup. I think they have to go together. And so I think that's the best place to go, is to probably start with a vendor. I can tell you that before we had a custom-based charting interface, I tried it for 2 years. It took me so long, I gave up. And so until we got the custom-based interface, I really wasn't willing to go in and do that work. So I wish I had a better answer in terms of, I mean, people can either create a custom interface or go to your vendor, but you need to have a solution for it, for the problem-based charting piece.
And I'll put in a little pitch from our perspective as a vendor, not of the EHR sort of main components itself, but the content. But in talking to both sides, because we deal with the big EHR vendors and we also deal with the customers, I've just put a little pitch in here for those of you out in the real world that the vendors really do listen to the field, so to speak, in terms of where they need to put their dev. And so, for a typical vendor, I would say writing software, number one, is regulatory. If it doesn't meet regulatory guidelines, you're not going to get anywhere. The second big thing for vendors is, I have to support you financially. You have to get paid for what you do. And then the third thing is, well, how does the EHR actually work for clinicians? And I think that's why it tends to get dropped down the list, or at least it has over the last 20 years or so, since the advent of the EHR. It's sort of number 3 on the dev timeline. Not that the vendors don't care about it, but the vendors really do listen to their customer feedback. I think I can speak to most of them around that, but don't hesitate to reach out and, you know, let them know. And I'm sure, Amber, you in your world have had a great deal of influence on your particular vendor in terms of what direction they're going. I feel like they're going in the right direction, by the way.
Yeah, absolutely. We talk to the vendor all the time about different ideas that we have and that we bring forward, for sure. I mean, I think what I will say to your point that you just made is, I think this is why we don't have problem-based charting and better tools for problem-less etiquette, is because it hasn't been part of the payment structure, right? So both for clinicians as well as for vendors, if you're leading, as Amanda led the conversation, with this concept of EHRs as regulatory and billing, that's why it hasn't risen to the level to get priority and to get built out. But if we tie together, you know, accuracy of documentation, you know, even quality matters, right? I mean, that's another way that I present the importance of the problem list to our clinicians is, if you want to do quality improvement or research in the future, we have to have an accurate problem list, because when we go to pull that registry for those patients, they're not going to be there if you're not billing and coding appropriately. So yeah, there's lots of reasons I think that this is the time to start saying problem-based charting will help drive problem list etiquette, and also drive our vendors and development, you know, software developers in the right direction.
Yeah, I think that's really a great point. You know, ultimately, you know, even though, you know, we all went into medicine to care for patients, we all went into medicine out of, you know, a sense of service, but at the end of the day, somehow the services have to be paid for, you know, if we want to keep our lights open. One of the things that I run into with that when I'm out working with physicians on just team-based care and delegation and things like that is helping people understand that it's not just, you know, the rendering clinician who's responsible for the problem list. There's a lot of different ways that different people in the care organization can help. So, for example, it doesn't have to be, you know, Amber or Jim or me at the point of care cleaning up that problem list. If an organization is deep into patient-centered medical home, some of that problem list maintenance can take place during daily huddles or other opportunities when people are caring for the patient indirectly. So maybe it's a care coordinator on the phone who can be empowered to help manage that problem list, or maybe it's ancillary personnel that the patient might be meeting with, like a dietitian or a diabetic educator. You know, I think we need to get to the point where we all understand that everybody owns the problem list. And as long as people are trained and you have appropriate roles and responsibilities, I think it's great to leverage some of those other folks on the care team to be able to do that work as well. I think physicians find it a little nerve-wracking at the beginning because they're so used to being kind of the ultimate gatekeeper of the problem list. But when I've seen it work really well with care teams, I think it's really impressive. All right, one last question, just kind of about EHR optimization in general. You know, we're talking about getting with our vendors, encouraging them to do things, doing clinical transformation within our organization, customizing displays. You know, just want to kind of get a feel for what people are seeing in the healthcare delivery community as far as how many resources organizations are devoting lately to things like EHR optimization. You know, we are just starting to come out of an unprecedented period of stress on healthcare, you know, where, you know, for a long period of time, a lot of organizations kind of dropped everything to deal with COVID and the sequela of COVID and everything else that happened due to that pandemic. Are you starting to see organizations having more budget or more ability to really work on these things, or is it still going to be a struggle over the next year or two? Let's start with that one with Jim.
We don't hear any organizations come to us and say we're loaded with money and we've got resources up the wazoo. Even though during COVID, you know, some of them struggled quite a bit. So, you know, as a vendor, we always face that dilemma of, hey, you know, what you have to offer looks great, but our budgets are really tight. I would say in general, I don't know that COVID is over, but certainly people have sort of gotten pretty good at managing what COVID is for them now. So it's still, the pandemic is still out there, but you know, we can at least start to focus on some other things, because certainly organizations set aside a lot during that time. And I would say in general, although I don't have a formal poll, our organizations that we deal with are very interested in saying we need to get to problem-oriented charting. We need to fix our problem list, yes, and we need to get to problem-oriented charting. So I think there is a bit of a, maybe more than a bit of a shift of focus from, hey, we're just trying to stay alive with all these patients coming in related to the pandemic in some way, to saying we can get back to making the EHR itself better. Amber, comments on?
Yeah, so I guess I'm going to make a statement that is, I don't think we can afford in healthcare not to optimize EHRs. So I think if organizations are taking a long, hard look at their turnover rate of staff and clinicians, and they're asking them and surveying them regularly about EHR helpfulness and harmfulness in the workplace, I think we can't not do this. So organizations are going to need to look at their burnout rates, look at their EHR satisfaction in their organizations, and then figure out where to get the budget to do this. I do think more and more organizations are supporting this. And my evidence for that is, since we got funded for our first sprint program in 2017, so it was pre-pandemic, we got funded for a second team in 2019 because it was so wildly successful with our end users, people saying like, oh my gosh, it's so nice to have specialty specific at the elbow team support for the EHR and for our workflows. And since we went live with those two teams, there have been at least 50 organizations across the country that we've worked with to build up similar optimization groups at their shops. So this is definitely happening. I mean, I think a lot of organizations now have some type of support. I think the biggest difference between what we do and what some organizations do is that we have both build and training as part of our optimization. And there are a lot of organizations that still only have training-based optimization, which doesn't get at the heart of some of the things we're talking about today, which is, building new interfaces or making things appear differently, or, looking at those IMO codes, or, all of those things take analysts to be involved and not just trainers. So we have to get there. Our organization is going to be asking for an additional budgeted sprint team each year for the next 3 years. So we're looking 3 years from now at having 5 built out sprint teams. Each of those teams costs $1.2 million a year. The cost of losing one physician is $500,000 to $1 million, is according to the AMA, in just trying to recruit and get a new physician. So I don't think, people look at us and say, wow, how did you get all that money? How did you get funded? The answer really is we started, with scraps, and we got a good reputation and we built on that. But this is something I think healthcare has to do. We have to go to the point of the clinician and the nurse and the MA and say, why is the EHR not working for you and your patients, and how can we make it different? We need to go to that point of care.
Yeah, I think that's really important. I know I said one last question, but one came in from the audience that I don't want to miss out on answering because I think it's really a key part of the discussion. The question is, what about billing stakeholders, including the payers? Do they have an awareness of the issues that clinicians have with using EHRs effectively to support clinicians' needs, or are they largely oblivious to the whole discussion? I'll at least talk a little bit about my experience. I was in a program a couple of years ago with embedded case managers from a particular payer. And that was actually really eye-opening for them because although they had their own case management software that they were using with the payer, they also had the opportunity to interact with our chart and see kind of the daily things that went on as far as what went well in the chart, what did not go well in the chart, and also the stresses that were placed on that chart, placed on the care coordinator role by having them documenting in 2 different systems. And I think that just gave them a little taste of what clinicians often encounter when we have to document things in 2 different places or things are not integrated. And actually they made some changes to the program as a result of being able to kind of feel that pain in the field. So, I can't speak to other organizations or what they might be seeing, but that was just kind of a little snapshot of a pilot program that I was in that evolved. Jim or Amber, have you seen any direct interaction with the payers as far as trying to help this problem?
I'll go first and be brief here and turn it over to Amber. I don't think the average payer really has much of a feel for what it's like in the clinical world. I'd hope that they do, but I think it feels like largely they're looking at a bill and whether or not it met certain criteria that are on that bill. And not so much the clinical side from the perspective of the clinician sourcing all the information that ultimately has to get distilled into an encounter that gets billed for. And I'd love to see that gap bridged a little bit, but right now it feels to me like they don't really have much idea on the payer side what it's like to generate a note.
Yeah, the only example that I'll give is the example that you talked about earlier with prior auths. So let's say that you're trying to prior auth CPAP or even a PPI on a patient or something like that. Right now, what happens, the staff basically prints out your note, which has 18 different problems on it that you addressed in addition to their GERD or in addition to their sleep apnea, and they send it off. So you have sort of a clinical but lesser trained person sending it to an insurance company where they're probably not clinical. With problem-based charting, you can say, just send me the notes on the sleep apnea, or just send me the notes on the GERD. And it very clearly says, this was the last sleep study, this is what I'm prescribing, this is what's affecting their sleep apnea. So you take that need to be clinical out, you sort of are distilling it under that problem. And so it's not exactly answering your question about like, is the insurance company somehow, going through and retrospectively looking at charts? No, but could it help with some of the processes where we interface with our billers and insurers? Absolutely.
Yeah, I think that's a really great point. So we do still have a couple of questions in the hopper, but we're rapidly running out of time, and unfortunately, I don't think any of them are quick answer questions. So I do want to thank the rest of the panel. Thank you to Amber, and thank you to Jim, and to our hosts at IMO for putting on this session today. And especially thank you to the attendees. I think this has been a great opportunity to talk about this. I appreciate you spending part of your day with us, and look forward to perhaps interacting with you at a conference or a meeting soon. Thank you, everyone.
Thank you to both of you.
Thank you.